Hi, my name is Corey Clark, and this is my second vascular case study for DMS 4410. Patient information for this case. So, a 58-year-old man presents to the ER with left-sided arm numbness, vertigo, and blurred vision. He is diabetic and a smoker for 25 years. A carotid duplex ultrasound and head and neck CT angiogram were ordered on behalf of the patient. Fasting lipid profile and blood glucose tests were ordered to determine risk factors for atherosclerosis. Normal imaging studies would look like this. You would clearly be able to see all of the arteries on the CT angiogram as well as the left subclavian artery on an ultrasound. In this case, our patient's exams did not look normal. There was a severe stenosis seen in the left subclavian artery, which measured 3 centimeters, and you could see stenosis on the ultrasound via the lack of flow where it should be, as indicated by that arrow on that image. Based on imaging and signs and symptoms of the patient, there were a few different differential diagnoses that included peripheral arterial disease, aortic stenosis, diabetic neuropathy, and subclavian steal syndrome. The diagnosis for this patient was subclavian steal syndrome. Subclavian steal syndrome due to the atherosclerosis in the subclavian artery. Incidence, the most recent prevalence in terms of large-scale studies concluded that 5.4% of subclavian steal syndrome cases were diagnosed in a series of 7,800 ultrasound exams of the extracranial neck vessels. The most common etiology of subclavian steal syndrome is atherosclerosis, which parallels with the physiology of the subclavian artery stenosis occurring proximally to the origin of the vertebral artery. Treatment for a subclavian steal syndrome depends on the severity of the pathology. Grade 1 shows reduced antegrade blood flow in the affected artery. Grade 2 shows a mixture of antegrade and retrograde blood flow in the affected artery. And Grade 3 shows permanent retrograde blood flow in the affected artery. Individuals with grades 1 and 2 can make lifestyle changes and take prescribed statins to lower the chance of atherosclerosis occurring. Individuals with grade 3 SSS are candidates for medications and surgical intervention. Surgical intervention for this condition determines on which side it occurs on. When the right subclavian artery is involved, an endarterectomy through a cervical approach is the preferred procedure. When the left subclavian artery is involved, a carotid subclavian bypass or ligation of the left vertebral artery is preferred. The prognosis for patients diagnosed with subclavian steal syndrome depends on if the underlying cause of the disease can be treated or managed. Some patients with subclavian steal syndrome can be treated through lifestyle changes and medication, while others will require surgery. For patients who can manage subclavian steal syndrome through lifestyle changes, and surgical patients who experience reestablished antegrade vertebral flow after surgical revascularization or stenting the subclavian artery, the prognosis is highly favorable. Subclavian steal syndrome is intimidating because patients may not experience any symptoms. An indicator of possible subclavian steal syndrome includes laboratory values expressing high chances for atherosclerosis. Patients can be prescribed statin medications to help with atherosclerosis, thus helping prevent subclavian steal syndrome. However, surgical intervention may be needed, as well as routine CTA scans and carotid ultrasounds depending on the stage at which SSS is caught. Patients' care teams should work closely to ensure the patient is having the appropriate scans, medications, and other measures so that subclavian steal syndrome can be handled preventatively versus surgically. For this patient, his etiology of subclavian steal syndrome was attributed to atherosclerosis due to smoking and diabetes. He was considered grade 3 for subclavian steal syndrome and underwent surgery. Since his left side was affected, his surgical team opted to do a carotid subclavian bypass. The patient fared well with surgery. His surgical team correlated follow-up CTA scans and carotid ultrasounds. After the patient was cleared to go home, he was instructed to follow up annually with a CTA scan and carotid ultrasound. His care team also recommended quitting smoking and placed him on statins as a preventative measure. This is an example of a protocol used to image a carotid ultrasound study, beginning with the common carotid artery, the bifurcation, internal carotid artery at proximal and mid, common carotid artery at proximal, mid, and distal, and the external carotid artery, and repeating that on the opposite side, including the vertebral arteries and the subclavian arteries. These are the reviews I used to complete this case study.